I'm going to start that again. Hi, my name is Dr. Andrew Wauchope. From a pathology perspective, we have had some questions from GPs regarding NT-proBNP. I've got quite a big packet of questions here. Let's get started. The first question, what conditions cause falsely elevated levels of NT-proBNP? The big one that we have to worry about is renal failure. In chronic kidney disease and with renal failure, the NT-proBNP accumulates in circulation and we get higher levels. So this does give us falsely elevated levels in the sense that it might not be related to the heart. The other things that give us falsely elevated levels are related to how the heart responds to the different diseases. For example, if you've got anemia or sepsis or a metabolic crisis, you might put more strain on the heart, and this does increase the NT-proBNP as well. A couple of other conditions that affect things like your water balance, so cirrhosis when you've got a lower albumin, and the way the heart responds to that also stresses the heart, and this can also increase NT-proBNP. So there's a number of conditions that do it from that perspective as well. So we do get a range of things that give increased amounts of elevation in NT-proBNP that aren't directly related to the heart, but most of them in some way are impacting the heart, except maybe for renal failure. So that was a great question. Why is NT-proBNP a better test in the community setting rather than in the emergency room? So I really like this question because to me, NT-proBNP has much bigger value in the community than it does in the emergency room. In the emergency room, there are lots of things and people to help you make your decision about someone who presents with potential heart failure. You can do an ECG, you can get a chest x-ray, you can do blood tests, and you can get an echocardiogram, and you can access specialists. In the community, those things can be obtained, but they're a little bit harder. And so it's much easier, or it can be easier, to do an NT-proBNP test, which helps you refer the patient in to get the other testing done. And so in the community setting, it's a great test to help you make a decision for your patient to get them seen for heart failure. And in the emergency room, it's a small add-on to everything else that is happening. Can I use NT-proBNP to monitor treatment in my patient? Good question. So under the Medicare benefit, no, you can't. Someone has to pay privately to get NT-proBNP used to monitor their treatment. It's not covered under the Medicare schedule of benefits. But if you do want to use it in this context, there's a lot of literature that might support it. This literature is a lot of primary studies where people have studied NT-proBNP to guide therapy. But when people do systematic reviews and compile all that data together, it doesn't come up as making a big difference to the outcomes. If you do want to use it, you've got to have a patient who's prepared to pay for it, and you've got to use it in context of knowing the literature that supports why you use it. What is the primary reason NT-proBNP is often preferred over BNP in the Australian community pathology setting? Well, this one's fairly straightforward. The NT-proBNP molecule is more stable than the BNP molecule in the blood sample once we've collected it. So therefore, in a community setting where we've got to transport the samples a greater distance into a laboratory, NT-proBNP is the test of choice. In a hospital setting, you've got less distance to transport the sample, and therefore you can do a BNP as well. But in the community setting, NT-proBNP is the preferred test. And from the evidence behind both tests, they're both equally good, and so there's no problem doing NT-proBNP in the community setting. Should gender have a difference regarding NT-proBNP levels? Another great question. So there's a difference in the population distribution between females and males with NT-proBNP. But when it comes to making the decisions around heart failure, the guideline committees have set single cut points for both men and women, so that we use the same cut points regardless of gender, even though there's a small distribution difference between the populations. Next question. What would be the appropriate referral pathway for urgent or non-urgent for a patient with suspected heart failure diagnosis and an NT-proBNP level of greater than 2,000 nanograms per liter? 2,000 nanograms per liter is a high value, and certainly that does suggest that heart failure is a major option in the diagnostic pathway. However, the decision about urgent or non-urgent referral is more about the clinical presentation. So if someone has symptoms of acute heart failure, they need to be seen urgently. And if it's chronic heart failure, the referral could wait a little bit to happen and doesn't need to be urgent. It could just happen in a routine way. And so it comes down to looking at your patient, deciding on the clinical symptoms. The referral pathway is not based on the blood level of NT-proBNP or BNP for that matter. It's based on the clinical symptoms that you have in front of you. The next question, is there a comorbidity known to cause a falsely low NT-proBNP level, potentially leading to a misdiagnosis of heart failure? So there is one comorbidity that does decrease the level of NT-proBNP and BNP, and that is obesity. We think a BMI of over 30 is where you need to start worrying about the impact on NT-proBNP. When you have someone with a higher BMI and you're suspicious of heart failure, even if your level is close to the cut point, I'd recommend still referring them for echocardiogram because that's going to give you a more definitive diagnosis. Remember, the NT-proBNP is like a test that guides you towards making additional investigations. It's not the definitive answer for heart failure. You still need to do echocardiograms and do other evaluations to make the diagnosis of heart failure. All right, next question. Does age affect diagnosis when interpreting NT-proBNP results to rule in heart failure in an acute setting? Age does affect all the BNP results. There are different cut points with different age groups. So the guidelines have different age groups stated in them, and we generate our reports to match those age groups. So you will see different numbers associated with different age groups in our reports. When it comes to ruling in heart failure in an acute setting, the same applies. So in our reports, we will tell you which age stratification is appropriate, and you'll get the appropriate interpretation. So look at the report that you get from the laboratory. What if the test is elevated, but the patient has no symptoms? So this is a really good question because you've had enough suspicion to order an NT-proBNP and it's come back elevated, but you've got a patient who's asymptomatic. It's still important to get that echocardiogram done to find information about how the heart is functioning and whether there's one of the forms of heart failure that has less symptoms. Picking up heart failure early enables better treatment. So still refer them for the echocardiogram. Well, here's a good question. What is something that excites you about the future of healthcare? I get excited about how we can use data in the future of healthcare. Computerized decision support that will enable you to order the right test at the right time for the right patient is something that's going to make a big difference in laboratory medicine. One, you'll get the correct tests when you need them. And the second benefit is by doing this, we should reduce unnecessary testing. And by doing that, we reduce the number of samples we collect, the waste in the system, and we protect our environment. So that's what excites me.